Professor Sunfik, she is right now in another hall.
So I'm going to pick on you, Rupesh, now. Now, we all know these are my financial disclosure, but I'm not particularly interested in syphilis from a financial standpoint. Now, we all know that syphilis is the great masquerader, but I will start my presentation by showing how much is masquerading just with the 3 cases. So we'll place, is it syphilis or is it not? We're going to start with 2 cases. Now, this is a 36-year-old male. This is autofluorescence. You see all these hyper dots here. You can see here some attenuation of the photoreceptors and RPE bumps. This patient is 42, more or less has a quite very similar appearance of hyper autofluorescent dots all around the fundus, and even here there's RPE bumps and attenuation of the photoreceptors. So is this one syphilis? Or is this one syphilis? Because to me, they look like mutes. I'm not going to pick on you, Rupesh, because you don't have, I mean, I should give you more data and more multimodal imaging, but this is to show you that they both look like mutes and they both look like syphilis. So the winner is actually this patient. This patient was sent actually with the diagnosis of AIM, and you see in both eyes there is this hyperautofluorescent plaques at the level of the macula and multiple dots all around. The vision is impaired. This is the appearance of the OCT that can help you, because in this particular eye you have all those RPE bumps that are quite typical of the placoid form of syphilis. So it's going to give you an idea. Then of course you test. This is the final follow-up of the patient, and you can see that on autofluorescence all the small plaques and the big dots are gone, and there's a restoration of the photoreceptors and the RPE. Now moving on to the second case. This is a patient that 28-year-old male, this FA looks like retinitis pigmentosa. Loss of photoreceptors, just preservation under the fovea. This is a bit older, 49-year-old male. Again, it looks like retinitis pigmentosa. Photoreceptors are more preserved here in the center. Now, is this syphilis or is this one syphilis? Because I promised one of the 2 is syphilis, but they both look like retinitis pigmentosa. Now, in this case, maybe the age could have told us, could have given us a couple of hints. This is the patient with syphilis. This is a patient that had cataract surgery in both eyes 6 weeks before, and he had the cataract extraction and steroids inside the eye, which are very, very bad idea in general. He did well, did a similar surgery, declined of vision. And this is not just vitritis, this is actually the steroids that were put inside the eye by the cataract surgeon. So in the fluorescein angiogram of the right eye, you can also see in the late phase this triangular shape here of hyperfluorescence that we're going to look at a bit later. And this can tell you that this could actually be an infectious disease, maybe syphilis. But in general, it's a horrible idea to put steroids inside the eye if you have no idea what's going on. So this is the OCT. The right eye, because of the steroids, had a more aggressive infection and wiped out of the photoreceptors. The left eye had a restoration of the photoreceptors. And then a final one. Is this 53-year-old man who looked like paravenous atrophy having syphilis, or is this 44-year-old female having paravenous pigmented atrophy? Now, this one is probably having more hyper in some areas with hypocentral. This is diffusely hypo with all these weird dots. Photoreceptors are attenuated and lost in both eyes. So is this one syphilis or is this one syphilis? There's no way of telling. They really look very similar. And this is the winner. This is one of the weirdest cases of syphilis that I've ever seen in my life. Now, if you look at the baseline autofluorescence, you see the fuzziness of the picture, and you see on FA how much all these blood vessels are leaking, the hot disc in both eyes. And after confirming, the patient was also HIV positive, so HIV is masking and muddling the picture even more. So this is the FA post-treatment. You see the fuzziness is gone, and all the FA, the hyperfluorescence, it's more defined, and same thing for the other eye in FA. And you can see autofluorescence. Here was more fuzzy, now it's much better and clear, but these dots of hypo, they will never go away probably. So we're talking about the great pretender. I hope I showed you that syphilis can look like everything. Can look like mutes, retinitis pigmentosa, and some paracentral pigmented, paravenous pigmented. History of syphilis. Why was it called syphilis? Because of Syphilos, which was a pastor, and he got punished by gods, and he got these particular illnesses. All you need to know about syphilis is that, except you Indians, every European population, they called it with the name of the other country they hated. For example, the French, they call it the Italian disease. But trust me, Italians are very, very clean in these things, and we don't have syphilis in Italy. Zero syphilis in Italy. So how do you get syphilis? If you practice in a country where there's a lot of syphilis, they come out with all these weird, the patients come out with all these weird things. So I got it in a public pool. I got it by sitting on a toilet. I got it, see, now he's cleaning because he thinks there's syphilis there. He got it at the laundromat because it was so dirty. But you all know how to get syphilis, so I'm not going to go into it. Now, for general practitioner and uveitis specialist, can we use imaging to unmask syphilis? No, we cannot. So I should just go away and drop the mic here. But I will give you a couple of hints because I like to look at patterns. So a couple of, more than a couple of hints with the multimodal imaging that can point you towards the right testing to get or the right referral. The first one is the superficial retina precipitate. This is an HIV positive male and RPR positive. You can see here all these deposits on top of the retina and the posterior hyaloid. These are quite typical. They were described by Emmett in the beginning. You can see them very often in the areas of ground glass appearance of syphilis retinitis. Now, if you talk to Emmett, he would say that he wouldn't call them precipitates because there's not a lot precipitating, but whatever, they point towards an infection, not just syphilis, an infection. They can also be found in toxo, for example. Multifocal retinitis is something I've never seen in my life, thank goodness, because it happens when you put steroids in an eye that has syphilis inside. So there are a bunch of reports. It has this particular appearance of hyper on OCT inside the retina. But what you usually find is a retinochoroiditis. Retinochoroiditis, chororetinitis, I'm not sure where it comes from. I think it's coming from the choroid, but it doesn't really matter at the end of the day. There are two main forms, the confluent and the placoid. Now, the confluent, the most typical one, has this ground glass triangular appearance with all these dots that we saw before. The denser appearance goes into a differential with acute retinal necrosis and toxo. It's very, very yellow and less ground glass. The most common is the ground glass, which is usually triangular, like in the patient that we saw before. It's a not dense, triangular shape. It has vasculitis and hyper of the margin in FA, and you have all this superficial retinal accumulation that we saw before. Now, the second most common form of retinochoroiditis is the placoid one, where you have this plaque at the level of the macula. This is a bit beyond the macula, and it's hyper on autofluorescence. Now, this is the OCT here is pretty diagnostic because it has all these RPE bumps. So, characteristic of syphilitic placoid chororetinitis is the plaque at the level of the macula. Why at the level of the macula? Because the choroid, if it's coming from the choroid, is thicker and has a higher volume of blood at the level of the macula. On FAF, the RPE bumps are hyperautofluorescence, and here on FA, there is a leakage of the whole area. See, he's liking my talk so much, he's actually telling home. He's telling people to come here. So on FA, there is a late leakage of the plaque. ICG showing hypo. Now, there's a debate about this. Probably they think that the choroid has areas of non-perfusion that are shown in ICG, and this has been proven on OCT as well, but we're not really 100% sure. Now, what's nearly diagnostic is the OCT. In the very early stage, you have subretinal fluid that goes away by itself, and then you have your typical RPE bumps. And then if you treat the patient, restoration of the photoreceptors. Now, the final one is papillitis, neuroretinitis. Whenever you see papillitis and subretinal fluid in uveitis, you have to think of everything, and syphilis as well. Now, this brings me to the next thing, which is if you have papillitis, you need to do a CSF testing. And in the CFS, you need to check for VDRL, because RPR has a high false negative rate, and FDA-ABS is sensitive but not specific. Now, serum testing. If you look at the CDC guideline, there's two algorithms. The traditional one, which is the one we've all studied, not treponemal and then treponemal, or the reverse one, which is syphilis IgG first and then RPR. The reverse is definitely cheaper and can detect previous treatment, but can only be used in low prevalence population. So treatment of neurosyphilis, we mentioned there's a shortage of penicillin. There are other alternatives, but they need to be managed and consulted by, with your ID doctor as well. So I thank you for your attention.
Thanks, Francesco. A masterly overview. Are there any questions from the audience?
I want to ask you, the secondary changes, secondary syphilis, you got rashes in the bodies, then in the hand you get a placoid lesions, confluent lesions. Same thing we are seeing in the retina choroid, where you see almost in end phase there are circular lesion, confluent lesion, and dot-like lesion. Is there any skin changes related to the retina choroid?
So I'm no dermatologist, but I'm not sure what the typical lesions that you see on the hand and feet, and I'm not sure you can call them placoid. I don't think a dermatologist would call them placoid. I think it's kind of erythema or something like this, but these are full of spirochetes. So my mentor in Cleveland, Dr. Lauder, taught me never to shake patients' hands because Cleveland has so much syphilis. So even before COVID, I was like this in the room. So I'm not sure. Just to answer your question, but I don't think placoid is the right definition if you consult a dermatologist for those lesions in the hand and feet.
Yeah. Any other questions? Yeah. I think the only comment I'd make is to absolutely agree with you that syphilis can look like anything, and the SUN criteria, the diagnostic criteria for syphilis, is a positive test, not a uveitis phenotype.
Thank you very much.